A ventricular assist device is an electromechanical circulatory device that is used to partially or completely replace the function of a failing heart. The function of VADs differs from that of artificial cardiac pacemakers. Some VADs are intended for short-term use, typically for patients recovering from heart attacks or heart surgery, while others are intended for long-term use, typically for patients suffering from advanced congestive heart failure. VADs are distinct from artificial hearts, which are designed to completely take over cardiac function and generally require the removal of the patient's heart. VADs are designed to assist either the right or left ventricle, or both at once. The type that is used depends primarily on the underlying heart disease and the pulmonary arterial resistance that determines the load on the right ventricle. LVADs are most commonly used, but when pulmonary arterial resistance is high, right ventricular assistance may become necessary. Long-term VADs are normally used to keep patients alive with a good quality of life while they wait for a heart transplantation. However, LVADs are sometimes used as destination therapy, meaning they will never undergo heart transplant, and sometimes as a bridge to recovery. In the last few years, VADs have improved significantly in terms of providing survival and quality of life among recipients. Design pumps. The pumps used in VADs can be divided into two main categories: pulsatile pumps, that mimic the natural pulsing action of the heart, and continuous flow pumps. Pulsatile VADs use positive displacement pumps. In some of these pumps, the volume occupied by blood varies during the pumping cycle, and if the pump is contained inside the body, then a vent tube to the outside air is required. Continuous flow VADs are smaller and have proven to be more durable than pulsatile VADs. They normally use either a centrifugal pump or an axial flow pump. Both types have a central rotor containing permanent magnets. Controlled electric currents running through coils contained in the pump housing apply forces to the magnets, which in turn cause the rotors to spin. In the centrifugal pumps, the rotors are shaped to accelerate the blood circumferentially and thereby cause it to move toward the outer rim of the pump, whereas in the axial flow pumps the rotors are more or less cylindrical with blades that are helical, causing the blood to be accelerated in the direction of the rotor's axis. An important issue with continuous flow pumps is the method used to suspend the rotor. Early versions used solid bearings. However, newer pumps, some of which are approved for use in the EU, use either electromagnetic suspension or hydrodynamic suspension. These pumps contain only one moving part. History. The first successful implantation of a left ventricular assist device was completed in 1966 by Dr. Michael E. DeBakey to a 37-year-old woman. A paracorporeal circuit was able to provide mechanical support for 10 days after the surgery. The first successful long-term implantation of an artificial LVAD was conducted in 1988 by Dr. William F. Bernhard of Boston Children's Hospital Medical Center and Themedics, Incorporated of Woburn, Massachusetts under a National Institutes of Health research contract which developed HeartMate, an electronically controlled assist device. This was funded by a 3-year $6.2 million contract to Themedics and Children's Hospital, Boston MA from the National Heart and Lung and Blood Institute, a program of NIH. The early VADs emulated the heart by using a pulsatile action where blood is alternately sucked into the pump from the left ventricle then forced out into the aorta. Devices of this kind include the HeartMate IPLVAS, which was approved for use in the U.S. by the Food and Drug Administration in October 1994. These devices are commonly referred to as first-generation VADs. More recent work has concentrated on continuous flow pumps, which can be roughly categorized as either centrifugal pumps or axial flow impeller-driven pumps. These pumps have the advantage of greater simplicity resulting in smaller size and greater reliability. These devices are referred to as second-generation VADs. A side effect is that the user will not have a pulse, or that the pulse intensity will be seriously reduced. Third-generation VADs suspend the impeller in the pump using either hydrodynamic or electromagnetic suspension, thus removing the need for bearings and reducing the number of moving parts to one. Another technology undergoing clinical trials is the use of transcutaneous induction to power and control the device rather than using percutaneous cables. Apart from the obvious cosmetic advantage, this reduces the risk of infection and the consequent need to take preventative action. A pulsatile pump using this technology has CE mark approval and is in clinical trials for US FDA approval. A very different approach in the early stages of development is the use of an inflatable cuff around the aorta. Inflating the cuff contracts the aorta and deflating the cuff allows the aorta to expand in effect the aorta becomes a second left ventricle. A proposed refinement is to use a patient's skeletal muscle, driven by a pacemaker, to power this device, which would make it truly self-contained. However, a similar operation was tried in the 1990s with disappointing results. In any case, it has substantial potential advantages in avoiding the need to operate on the heart itself and in avoiding any contact between blood and the device. This approach involves a return to a pulsatile flow. Peter Horton was the longest surviving recipient of a VAD for permanent use. He received an experimental Jarvik 2000 LVAD in June 2000. Since then, he completed a 91-mile charity walk, published 2 books, lectured widely, hiked in the Swiss Alps and the American West, flew in an ultralight aircraft, and traveled extensively around the world. He died of acute renal failure in 2007 at the age of 69. Studies and outcomes. Recent developments. In July 2009 in England, surgeons removed a donor heart that had been implanted in a toddler next to her native heart, after her native heart had recovered. This technique suggests mechanical assist device, such as an LVAD, can take some or all the work away from the native heart and allow it time to heal. In July 2009, 18-month follow-up results from the HeartMate 2 clinical trial concluded that continuous flow LVAD provides effective hemodynamic support for at least 18 months in patients awaiting transplantation, with improved functional status and quality of life. Heidelberg University Hospital reported in July 2009 that the first Heart Assist 5, known as the modern version of the DeBakey VAD, was implanted there. The Heart Assist 5 weighs 92 grams, is made of titanium and plastic, and serves to pump blood from the left ventricle into the aorta. A Phase 1 clinical trial is underway, consisting of patients with coronary artery bypass grafting and patients in end-stage heart failure who have a left ventricular assist device. The trial involves testing a patch, called angina, TM, that contains cells that secrete hormone-like growth factors that stimulate other cells to grow. The patches are seeded with heart muscle cells and then implanted onto the heart with the goal of getting the muscle cells to start communicating with native tissues in a way that allows for regular contractions. In September 2009, a New Zealand news outlet, Stuff, reported that in another 18 months to 2 years, a new wireless device will be ready for clinical trials that will power VADs without direct contact. If successful, this may reduce the chance of infection as a result of the power cable through the skin. The National Institutes of Health awarded a $2.8 million grant to develop a pulseless total artificial heart using 2 VADs by Micromed, initially created by Michael DeBakey and George Noon. The grant was renewed for a second year of research in August 2009. The total artificial heart was created using 2 Heart Assist 5 VADs, whereby one VAD pumps blood throughout the body and the other circulates blood to and from the lungs. Heartware International announced in August 2009 that it had surpassed 50 implants of their Heartware ventricular assist system in their advanced clinical trial, an FDA-approved IDE study. The study is to assess the system as bridge to transplantation system for patients with end-stage heart failure. The study, Evaluation of the Heartware LVAD system for the treatment of advanced heart failure, is a multi-center study that started in May 2009. On June 27, 2014, Hanover Medical School in Hanover, Germany performed the first human implant of HeartMate 3 under the direction of Professor Axel Havik MD, Chief of the Cardiothoracic, Transplantation and Vascular Surgery Department and surgeon Jan Schmittou, MD, Ph.D. On January 21, 2015, a study was published in Journal of American College of Cardiology suggesting that long-term use of LVAD may induce heart regeneration. This may explain the bridge to recovery phenomenon first described by the Yaku group in NEJM in 2009. The majority of VADs on the market today are somewhat bulky. The smallest device approved by the FDA, the HeartMate 2, weighs about 1 pound and measures 3 inches. This has proven particularly important for women and children, for whom alternatives would have been too large. One device gained CE mark approval for use in the EU and began clinical trials in the US. As of June 2007, these pumps had been implanted in over 100 patients. In 2009, Ventricle was placed into the hands of administrators due to financial problems and was later that year liquidated. No other companies purchased the technology, so as a result the VENTR assist device was essentially defunct. Around €30-50 patients worldwide remain supported on VENTR assist devices as of January 2010. The hardware HVAD works similarly to the VENTR assist albeit much smaller and not requiring an abdominal pocket to be implanted into. The device has obtained CE mark in Europe, and FDA approval in the US. Recently, it was shown that the hardware HVAD can be implanted through limited access without stenotomy. In a small number of cases, left ventricular assist devices, combined with drug therapy, have enabled the heart to recover sufficiently for the device to be able to be removed. HeartMate 2 LVAD pivotal study A series of studies involving the use of the HeartMate 2 LVAD have proven useful in establishing the viability and risks of using LVADs for bridge to transplantation and destination therapy. The pilot trial for the HeartMate 2 LVAS began in November 2003 and consisted of 46 study patients at 15 centers. Results included 11 patients supported for more than 1 year and 3 patients supported for more than 2 years. The HeartMate 2 pivotal trial began in 2005 and included the evaluation of HeartMate 2 for 2 indications, bridge to transplantation and destination therapy, or long-term, permanent support. Thorotec Corporation announced that this was the first time the FDA had approved a clinical trial to include both indications in one protocol. A multicenter study in the United States from 2005 to 2007 with 113 patients showed that significant improvements in function were prevalent after 3 months, and a survival rate of 68% after 12 months. Based on 1-year follow-up data from the first 194 patients enrolled in the trial, the FDA approved HeartMate 2 for bridge to transplantation. The trial provided clinical evidence of improved survival rates and quality of life for a broad range of patients. 18-month follow-up data on 281 patients who had either reached the study endpoint or completed 18 months of post-operative follow-up showed improved survival, less frequent adverse events and greater reliability with continuous flow LVADs compared to pulsatile flow devices. Of the 281 patients, 157 patients had undergone transplant, 58 patients were continuing with LVADs in their body and 7 patients had the LVAD removed because their heart recovered. The remaining 56 had died. The results showed that the NYHA class of heart failure the patients had been designated had significantly improved after 6 months of LVAD support compared to the pre-LVAD baseline. Although this trial involved bridge to transplant indication, the results provide early evidence that continuous flow LVADs have advantages in terms of durability and reliability for patients receiving mechanical support for destination therapy. Following the FDA approval of HeartMate 2 LVAD for bridge to transplantation purposes, a post-approval study was undertaken to assess the efficacy of the device in a commercial setting. The study found that the device improved outcomes, both compared to other LVAD treatments and baseline patients. Specifically, HeartMate 2 patients showed lower creatinine levels, 30-day survival rates were considerably higher at 96%, and 93% reached successful outcomes. HARPS The Harefield Recovery Protocol study is a clinical trial to evaluate whether advanced heart failure patients requiring VAD support can recover sufficient myocardial function to allow device removal. HARPS combines an LVAD with conventional oral heart failure medications, followed by the novel I2 agonist clenbuterol. This opens the possibility that some advanced heart failure patients may forego heart transplantation. To date, 73% of patients who underwent the combination therapy regimen demonstrated sufficient recovery to allow explantation and avoid heart transplantation. Freedom from recurrent heart failure in surviving patients was 100% and 89% at 1 and 4 years after explantation, respectively. Average ejection fraction was 64% at 59 months after explantation. All patients were NYHA Class I. And no significant adverse effects were reported with clenbuterol therapy. Rematch. The Rematch clinical trial began in May 1998 and ran through July 2001 in 20 cardiac transplant centers around the USA. The trial was designed to compare long-term implantation of left ventricular assist devices with optimal medical management for patients with end-stage heart failure who require, but do not qualify to receive cardiac transplantation. As a result of the clinical outcomes, the device received FDA approval for both indications, in 2001 and 2003, respectively. The trial demonstrated an 81% improvement in 2-year survival among patients receiving HeartMate XVE compared to optimal medical management. In addition, a destination therapy study following the Rematch trial demonstrated an additional 17% improvement in 1-year survival of patients that were implanted with a VAD, with an implication for the appropriate selection of candidates and timing of VAD implantation. A test carried out in 2001 by Dr. Eric A. Rose and Rematch study group with patients with congestive heart failure that were ineligible for a transplant showed a survival at 2 years of 23% for those implanted with an LVAD compared with 8% for those who were treated with drugs. The two major complications of VAD implantation were infection and mechanical failure. According to a retrospective cohort study comparing patients treated with a left ventricular assist device versus inotrope therapy while awaiting heart transplantation, the group treated with LVAD had improved clinical and metabolic function at the time of transplant with better blood pressure, sodium, blood urea nitrogen, and creatinine. After transplant, 57.7% of the inotrope group had renal failure versus 16.6% in the LVAD group. 31.6% of the inotrope group had right heart failure versus 5.6% in the LVAD group. And event-free survival was 15.8% in the inotrope group versus 55.6% in the LVAD group. Complications and side effects. Bleeding is the most common post-operative early complication after implantation or explantation of LVADs, necessitating reoperation in up to 60% of recipients. The implications of massive blood transfusions are great and include infection, pulmonary insufficiency, increased costs, right heart failure, allosensitization, and viral transmission, some of which can prove fatal or preclude transplantation. When bleeding occurs, it impacts the 1-year Kaplan-Meier mortality. In addition to complexity of the patient population and the complexity of these procedures contributing to bleeding, the devices themselves may contribute to the severe coagulopathy that can ensue when these devices are implanted. Critical in the management of bleeding in the early hours after implantation or explantation is to adequately evacuate the post-surgical blood from around the heart and lungs to prevent retained blood from contributing to the need for reoperation to wash out clot that can compress the device features and contribute to post-operative shock. Preventing chest tube clogging during this period is critical to recovery. Because the devices generally result in blood flowing over a non-biologic surface, predisposing the blood to clotting, there is need for anticoagulation measures. One device, the HeartMate XVE, is designed with a biologic surface derived from fibrin and does not require long-term anticoagulation. Unfortunately, this biologic surface may also predispose the patient to infection through selective reduction of certain types of leukocytes. New VAD designs which are now approved for use in the European Community and are undergoing trials for FDA approval have all but eliminated mechanical failure. VAD-related infection can be caused by a large number of different organisms, gram-positive bacteria, gram-negative bacteria, fungi. Especially Candida species, treatment of VAD-related infection is exceedingly difficult and many patients die of infection despite optimal treatment. Initial treatment should be with broad-spectrum antibiotics, but every effort must be made to obtain appropriate samples for culture. A final decision regarding antibiotic therapy must be based on the results of microbiological cultures. Other problems include immunosuppression, clotting with resultant stroke, and bleeding secondary to anticoagulation. Some of the polyurethane components used in the devices cause the deletion of a subset of immune cells when blood comes in contact with them. This predisposes the patient to fungal and some viral infections necessitating appropriate prophylactic therapy. Considering the multitude of risks and lifestyle modifications associated with ventricular assist device implant, it is important for prospective patients to be informed prior to decision-making. In addition to physician consult, various internet-based patient-directed resources are available to assist in patient education. List of implantable VAD devices. This is a partial list and may never be complete. Referenced editions are welcome. See also, intra-aortic balloon pump, Gus Rosenberg. References. External links, LifeFlow LVAD at the University of Virginia, Nader Moazami, Patrick M. McCarthy. Temporary circulatory support, Eugene L. Kukai, Mehmet Cioz, Yoshifumi Naka. Long-term mechanical circulatory support. A review of the subject as at 2003. Mechanical Circulatory Support Resource Center, Health Center Online. VAD, Mayo Clinic. VAD, Life Without a Pulse. A news story about Canadian man with VAD, heart pump design could give patients new hope. A new counter-flow heart pump developed by Queensland University of Technology. Heart pump improves quality of life in congestive heart failure patients. A rapid review of the medical literature and specialist opinion as at December 2005, National Institute for Health and Clinical Excellence. Interventional procedures overview. A short-term circulatory support with left ventricular assist devices as a bridge to cardiac transplantation or recovery. A rapid review of the medical literature and specialist opinion as at December 2005, Courtney J. Giamato, Matthew D. Forrester, Timothy J. Myers, O.H. Frazier, Denton A. Cooley. 35 years of mechanical circulatory support at the Texas Heart Institute. Tex Heartins J. 2005. 32 168-77, mylvad.com. Non-branded site with video, news, and community discussions on VADs. Ventricular Assist Device Center for Heart Failure. Northwestern Memorial Hospital, 1, website Hanover Medical School. LVAD FAQ.